Well, good evening, everyone, and welcome. I'd like to welcome our special guest this evening, our good friend and colleague, Mathew Zacharias. And Mathew is going to talk about something that he's particularly well qualified to talk about. It's the anaesthesia artifacts in the 20th and 19th century as part of the Ritchie Collection, which he knows a great deal about. So please welcome our speaker, Mathew Zacharias.
Thank you very much. Can you hear me okay? Right. Probably my special qualification to give this talk is that I am 41 years old today, this year. And I like old things. You should see my house, it's full of old things. Okay, I came to Dunedin in 1989. To my surprise, when I walked into the Ritchie Room, I found it was like an Aladdin's cave for me. The reason which I was surprised was that most of the things were things I have used in my life as an anesthetist. Because I'm from India, and we are a very poor country, and we had to use old things in the old-fashioned way. And then I came out of India went to Ireland and trained there in a different system. My initial training in anesthesia is essentially to deal with kind of low-quality equipments, but give a safe anesthesia. Now, my introduction to anesthesia, I think I need to tell you the story. It starts in 1965, when I became a third-year medical student. And it was a new medical school, and we didn't have any hospital. So they borrowed a district hospital, and we were trained there. And our term starts on the 1st of June every year in all institutions. So on the 1st of June, 1965, I walked into the hospital. By the way, 1st of June is inevitably the start of monsoon in my part of the world. Exactly on the 1st of June, it starts raining for about 3 months. So I ducked the rain and went to the hospital, found out I am with a professor of surgery in the operating theater. And I walked in there, and I opened the door, and the professor was doing the operation. And there was a lady, and he had a couple of nurses with him. And there was a lady sitting on a kind of stool at the foot end of the bed, the patient, doing something to the patient. And professor was operating in his tummy. And as soon as he opened the door, the lady said, "Come in, come in." And she said, "Come and sit on this stool." So I sat there. She gave me that mask over there and that bottle, one like that, and told me to hold the mask and pour the liquid into the mask. I'm just going out to the toilet for a minute. And she just disappeared. Remember, I was the first day I get into any hospital. Yeah, here it is. Now, if you haven't heard or seen or anything about using ether in the old-fashioned way, the way I used it on that particular day.
The simplest method of inducing anesthesia is by dropping ether onto a mask through which the patient inhales the vapor. Although better results can be obtained by more elaborate methods, ether is relatively safe.
That's fine, thank you. Okay, and I haven't finished the story yet. So I was kind of pouring that in, and everything was fine for about 5 minutes. Then professor suddenly looked up and said, why is the patient blue? Well, you see, he's not breathing. And then I had no idea what it was all about. And then he had a look at me and said, who are you? I said, I'm a medical student. He didn't curse me or anything. He said, okay. He told me, he given me a few instructions. He said, lift the chin up. So I lifted my chin up. No, not your chin, patient's chin. So I lifted the chin up and he started breathing due to some reason. And then he said, stop pouring that thing onto the mask. Take your time. Give it a minute in between and pour it again. So I started doing like that, and the patient started breathing. And after about 3 minutes, he started operating again. He said everything is fine. After about 10 minutes or so, the lady who was there came back and opened the door with a glass of tea. We didn't have mugs in those days, so we always coffee or tea was drank in a glass. She had a glass of tea on one hand and some kind of thing, a biscuit in the other hand, and opened the door and asked me, how is the patient? Professor then said that, oh, patient is fine, he's doing well. So, and then she came and taken over the case after another 5 minutes. I was very happy at that time. So basically, two things that professor told me that day. One thing, you make sure patient breathes. Other thing is you give the anesthetic in moderation. In fact, those are probably the two principles in anesthesia which we all learn. I learned it on the first day as a medical student, but usually they spend about 5 years now trying to learn that principle. So if you talk about anesthesia, in the old days, like pulling a teeth or something, they either give a bang on the head or pray or give alcohol or opium or use brute force and take it out. But then people started inventing various drugs like nitrous oxide. It was used in 1844 for taking a tooth out. Then ether came in, and somebody called William Morton in 1846 anesthetized a patient, and somebody removed a tumor from the neck. Then James Simpson, the Scottish fellow, gave chloroform during delivery in 1847. Then this fellow, John Hayfield, in 1847 actually used ethyl chloride. These were the only anesthetics available for very long time, till really to the mid-1900s. So the first anesthesia was done in 1846 in Massachusetts General Hospital. If you go to Massachusetts Hospital, you can see a little old hut-like thing right in front of it as you walk through the little bridge there. And if you get inside, you can see almost the same kind of appearance with nobody in it, with a stinky smell. That's all what you get now. But you can see where it all happened. First anesthesia in New Zealand was a year later. It was in Wellington jail. Obviously, it was a prisoner. He got ether. The anesthetist was an optical instrument maker. He made his own anesthetic inhaler and gave the anesthetic. Mind you, in those days, anybody could give an anesthetic. I could give an anesthetic later on as a medical student. So that's the way. Anybody could give an anesthetic in those old days. The rules were very loose. Similarly, surgeons were either butchers or barbers and things like that, and they did operation on the side. But those days are gone. Now, John Ritchie, as you would know, he was the associate professor of anesthesia here for a long time. He was basically a gadget man, and he was intensely interested in teaching students, medical students and dental students. He actually developed anesthesia in and around Dunedin. Ritchie Collection was it's actually currently located on the 5th floor in this hospital and on the foyer of the 5th floor. I can tell you that it is one of the oldest and largest collections of anesthesia artifacts in Australasian area. We have quite a lot of things in that collection. Where did it come from? From our hospitals, and the country practitioners gave it. There are a lot of small hospitals around here. They all, when they were closed down, and so sent it to us. And probably the primary source was hospital ships, which was used in First World War. The ships Mahino and Marama. If you would know that those two ships were actually commercial ships in Port Otago, but they were converted into hospital ships and used for transporting soldiers as well as injured people to and from New Zealand to the front area in Europe and then back. So it had everything inside there to treat people and beds to look after them. So all the items were, when the ships were decommissioned at the end of the war and returned as ordinary ships for commercial reasons, all the documents were uploaded, and at that time the New Zealand government decided to have a special hospital for training doctors and nurses for war situation. That's how the Marama Hole was built originally. It was to train the doctors for training for war purposes. But they soon decided against it, and the hole was converted, given to the university, and it is now the music department. It's called Marama Hole, not Marama and Mahino Hole, which was originally intended. Professor Baker came and resurrected the collection, and he got one of the registers at that time, Duncan Gallatly, and he made a lot of arrangement and indexing of that items to some extent. Jim Clayton was a long-standing head of the department here in this hospital. He was very helpful in that during the time when the various changes happened to the hospitals and health systems, we had hell of a number of managers, and they were looking for places to have their offices. So they tried their level best to get rid of, to take over that Ritchie Room and get rid of the things and make them offices for managers. Jim fought against it and won, so we still have that room. Jim wrote a book about history of anesthesia in Dunedin Hospital. I think he has given a presentation about it in this forum some years ago. And anybody who wants that book can get a book from Jim. He has a couple of extra ones in his house. Then there is a period of turbulence where the items were shattered around. We had a lot of places around the hospital. The Department of Anesthesia had a lot of places around the hospital and university, but they were all taken over. All the old items were thrown out into various disposal areas. So I fought hard to try and keep as many as I could. So I got really, either I can bang my head and put my hair out or accept the inevitable. So I decided that I will accept the inevitable. I realized that happiness is when you lower your expectation to whatever is the reality. So I was very happy, whatever I had there. So we did, actually, I got a medical student. Luckily, somebody paid for a medical student. She's a doctor now. She worked with us for a couple of years off and on, and photographed and cataloged all the items. We are secured on the 5th floor and in the foyer there. And we have a book published about with the photographs and some description of all the items. And all these items are in the eHive database under the title Ritchie Collection. Chris looks after the database, so he would know more about it. This is the book we published. And don't worry about any of that. That's the various lists. But if anybody wants to go and find out what are the sections and how to access the eHive, this is given here. There are 23 different groups and total of 283 items are classified in the catalog. Some items are multiples of many of the same items. Some bits are still there to be classified, but somebody else can do it, I suppose. Now, coming to the items, they have been used for a long, these are drugs which have been used right from the beginning of anesthesia. Chloroform, we have samples of all this up in the collection. Ether and ether chloride. I don't think any of them are used for anesthesia anymore. Certainly, I have used all of them. I'm probably one of the still living anesthetists, even though I don't practice now, who have used all these anesthetic agents in the collection. And from the mid-1950s, a lot of new anesthetic drugs, inhalational anesthetic agent. Basically, you breathe the vapors of it, you go to sleep. And there are lots of them. There are samples of all of them are there in the collection. Then there are anesthetic gases, nitrous oxide. Even yesterday in the television, it was there that people are getting nitrous oxide in little capsules, like the like the photo shown here. This one. There are a lot of other anesthetic agent comes in little capsules like that, and this is the system whereby you can inhale those ones. They used to give it to patients for various reasons. This is nitrous oxide, and this is cyclopropane. Nobody uses cyclopropane anymore because it had certain disadvantages. It is explosive to start with, like ether. They explode with the oxygen. These are some of the original masks there. Essentially, it's a kind of mold a wire and put a lint on it and pour the anesthetic onto it, and you go to sleep. It's simple as that. These are from very old times, 1860, 1890. These are Schimmelbusch masks. I can tell you that I've used it hundreds and hundreds of times to anesthetize people of all ages. And we have a lot of these ones lying upstairs in the collection. And you keep either ether, generally ether is the drug used in the 1900s, but chloroform was used anyway, again, many people have used chloroform onto this mask successfully in many locations. And then we have, people have gradually changed from simple wireframe mask into various gadgets. It's a progression over the years. For example, they used this so-called Murphy's inhaler. We have put in a lint over here and then put chloroform in it, and then they breathe through that and they go to sleep. These are Jenger's chloroform inhaler, again from 1860s. If you can see, look at this bottle up here, and you use the pump and pump in air into that, and there is chloroform in the bottle, and then through another tube, it connected onto this mask. It's a metal mask, sits on the patient's face, and you pump in the chloroform with air through that into the mask, and patient goes to sleep. These are gradual modifications of it. And then this is clover ether inhaler, again from 1870s. If you look at it, there is a handle around here. Basically, you can move it around and adjust the amount of air getting in, so that you can change the concentration of ether which is stored inside this bulb. So they are slowly learning or beginning to change the concentration of, or have some control of what the concentration is going in. Again, this is ship apparatus. It was done in around the wartime. There were few of them sitting in the collection. The reason is that they came from the warships, Mahino and Marama. They were used by the New Zealand Army at that time. Again, it is kind of either chloroform or either they sit in kind of water bath. The reason is that whenever an anesthetic vaporizes, it cools down. So to prevent it getting really, really cold, ice cold, they put water in it or hot water in it so that the process of vaporization continues. Then there is a series of anesthetic machine used by this person called Boyle. He's an Englishman. There are different versions of it. Essentially, you collect anesthetic in these bottles and use these cylinders up here and pump in oxygen or with or without nitrous oxide, and it goes through those tubes into the patient and they go to sleep. And there are different advancements in it. Later on, the versions, the modifications of the same anesthetic machine, it comes in better and better format. In fact, all countries which are somehow linked to the United Kingdom, like Australia, New Zealand, or India, or Pakistan, we all had the same kind of machines for a long number of years. For about 40 years, I have used this particular anesthetic machine. When I came here, we had the same kind of machine, this one, the modified, the modern version of it. Modern means in the 1960s. And we got rid of it only in around 2000 or late 1990s. In fact, there is only one of them left, and there is no place to keep it, so it is sitting in my garage. I don't know what I will do. I will probably put it in my will that it goes to Chris. I love it. It's a very simple, easy machine to use. I could repair it myself if I wanted. Then I showed you this one earlier. You start increasing the delivery, make it smoother, like putting in a water bath so that vaporization happens. And then they started controlling the concentration delivered by the machines. They've improved it and used, for example, this one has got, it can control the temperature because it has got a large piece of copper, made of copper inside. So it actually regulates the temperature easier. And then the modern ones are vaporizers. You tend to get both control of the temperature as well as the flow of the gases you give. It adjusts itself. They all aim to get a steady concentration delivered to the patients. Talking about Ritchie, one of his great inventions was he developed something called Ritchie whistle. It's a kind of gadget. You stick it in the anesthetic machine. Every time or any time if the concentration of oxygen in the system falls, it gives an alarm so that you don't give harmful amount of other gases. So it is a great invention. They used it quite a long time. With all the Boyle's anesthetic machines had this one. So we call it Ritchie whistle. Gradually, they started developing better ways of delivering anesthetic to the patient. For example, this kind of bellows shown here. You can pump in air into it, into this machine. It's called Epstein McIntosh Oxford vaporizer. Put either in it. You can adjust the concentration of it. This was very popular in the 40s and 50s and 50s and 60s, especially when you don't have much access to oxygen. We had lots of them at home in India. We can give pretty controlled amount of ether to the patient for long surgery and ventilate the patient with this bellows because we didn't have any other ways of ventilating patients at that time. This was actually invented, one of the part inventors was fellow called Robert McIntosh from Timaru. I'll come to it again. This is the Oxford Bellows. This is one of the early ways of helping us to ventilate patients. And of course, now everything is automatic ventilators. This is a simple bag system. You just squeeze it down, and it's only a unidirectional valve here. Air goes into the patient with or without an anesthetic. This is, and again, during the Vietnam War, they wanted to resuscitate patients and give artificial ventilation away in the field. So they developed this so-called ambu bag or airway bag. This is extensively used in various wars. Out in the field, they are very, very good. Now every bed in the hospital seems to have one of them. Now they have modified it and became almost disposable. You can just use once and throw it away. These things were, of course, reused, and we have a model here from 1950s. Analgesia was delivered, for example, in obstetrics by different ways. Cardiff inhaler was one of the ways. Now, of course, you can have handheld inhalers, and this is methoxyflurane, which is a very good analgesic. If you get injured and get into the ambulance these days, they give you one of these things to breathe into. It is very good analgesic to breathe in and control your pain. Oral airways are basically to keep the airway patent. Remember, when I got into trouble on my first day as a student, one of the first things that my professor told me to was lift the chin up, essentially to make sure there is a passage for air to go. It becomes easier if you put one of these airways. It used to be metal ones, then it became rubber ones, and then became anti-static rubber and plastic later on. Now they are throwaway plastic ones. Use it once and go out. Otherwise, we have to clean all of it and reuse it multiple times. We have all those ones here. Face mask, again, you put it over the patient's face so that they can breathe the anesthetic or whatever you want to breathe. It was metal, but gradually they added rubber into it and made of rubber so that less trauma to the face, and then anti-static rubber. And now it is all plastic and throw away. Needles, I'm sure the older people have used it before the plastic disposable Canadas came in. They all had problem of keeping it there, so we had various wings and other things built into it. They are called Mitchell's needles. You can keep it there and lock itself, and you can connect the drip at the end of it. And these were the sharp things we used to clean them inside so that we could reuse them. So one of the main job was of the nurses and technicians were clean it and sterilize it every evening. But those days are gone. Now everything is disposable. Intravenous anesthetic drugs, once barbiturates were introduced in say 1920s, it becomes a lot easier. Thiopentone was probably the most acceptable barbiturate drug ever used in anesthesia, but it's gone out of fashion now in last 10 years or so. It was extensively used because it is very easy to use, very predictable effect, long sleep. In fact, when it first came, if you can remember, Pearl Harbor attack was in 1941. And a lot of the anesthetists at that time didn't know that it has got certain problems if you give a lot of thiopentone. So they give, unfortunately, a lot of patients in Pearl Harbor, they wanted to do the operation to hurry it up. They gave a lot of thiopentone or pentothal to the patients, and half of the patients died were actually due to overdose of or side effects of thiopentone because they didn't realize some of the some of the facts, like you shouldn't be giving it in a patient who is in shock. But after that, they learned a lot about it, and it has been extensively used for many years. Local anesthetic, we had started with procaine, and a lot of better drugs came in, lignocaine and marcaine or bupivacaine. The older ones are all replaced, and basically only lignocaine and bupivacaine are used at the moment. Oxygen was available for everything, particularly in small miniature cylinders. They had various gadgets giving oxygen. There are few different gadgets up in the display to give oxygen in an emergency. This, for example, oxygen and helium, which was very useful for people having respiratory breathing difficulties like severe asthma. It reduces the resistance to breathing. Muscle relaxants came, curare being the first one, and lasted for a very long time until they started having alternative ones. Now there are much better drugs, but we have samples of all the old ones in the stock. Endotracheal tubes is an interesting story. Soon after the First World War, a lot of people had facial injuries and needed plastic surgery around the face. So some of the hospitals in London decided to have some way of maintaining breathing and prevent blood going into the lungs during the operations. So they decided to put in tubes into the trachea. First they tried metal tubes, then they tried rubber tubes, and then they have cuffed rubber tubes. And that's how they started in 1918, 1920, at that kind of time, soon after the war. Then that developed into various better tubes, and there are tubes available which can isolate two lungs and block one lung for surgery. Those kind of tubes are there. These are all rubber ones. They are all museum pieces now because current ones are all made of plastic and throwaway ones. These are called laryngeal mask airways. Pretty recent one, about last 25 years or something. You put it in the mouth and inflate the balloon so that you don't have to put anything into the trachea. You get a good seal and you can breathe or artificially ventilate through that. Now again, these are reusable ones, but now the present ones are all throwaway plastic ones. Similarly, tracheostomy tubes. There are metal tracheostomy tubes where made of silver and used for multiple times. Now they are all disposable plastic ones. Laryngoscopes are, of course, to visualize the trachea and place tubes and other things there. There are different types. McIntosh, the fellow I was talking about, made this one. There are different types and it's available with us. Now, these are two great people in anesthesia. I met both of them at a meeting in Hamburg in 1980. Everybody has gone for a cup of tea and refreshments. And I went around, looked at the old inventions and old things around there. And then I found these two people with their wives coming and seeing their own inventions, which are displayed there. I was pretty impressed by them. And I still remember, and I had a long chat with them because I was the only one there. So they wanted to tell me what they did, and this, I did that, and I did this kind of thing. And I remember Professor Magal telling me at that time, by the time you reach my age, he was around 75 or something at that time, you will notice that anything which is there available now will disappear. It will all be new things. He's right. The things I started anesthesia with all gone. It's all new equipment, machines, everything. These are artificial ventilation started with simple ventilators, but we had ways of, we had to measure how much volume was given to the patient by this artificial. So we used to have cumbersome looking items added onto the system. These were alarms. There is a disconnection of the tubes or something, it will alarm. So these were all safety ones. Now they are built in by and use various chips to find out all these much easier now. Dental anesthesia was particularly important in Dunedin because of the fact that we have the dental school. And Professor Ritchie was exceptionally good in teaching and innovating in dental school. He was actually very keen on teaching every dental student how to anesthetize patients for dental surgery. Remember, in those days, until quite recently, they could give anesthesia themselves. Even now, only in the last 5 years, there are rules that they shouldn't be anesthetizing. Otherwise, they could anesthetize in the dental surgery. There are foot pumps, for example. This one is you press air through that into anesthetic pumps, and they could deliver it. And these are foot sections. They're all models sitting there in the display. Now, this is an ear oximeter. Now, you go to any hospital, you see the oximeters sitting around and bleeping near every patient. It detects the saturation of oxygen in their bloods. These were different. These were huge, big machines, and this ear clip was connected on the ear, and they allow it to warm. Inevitably, a few people had burns. But what it does is, when the ear is warm, you can measure the change in the color. So that's how they decided the amount of oxygen in those days. Now they work on a different principle. They can measure, they use a piezoelectric crystal, measure the oxygenated hemoglobin. These are carbovisor. Again, they were able to measure carbon dioxide continuously if necessary, but they are cumbersome machines, and we have one here. That was before, by 1940s and 50s. There's no big way of measuring carbon dioxide in the patient or in the system. So they had to use these big machines. Now, of course, everything is recorded, simple breath measurement of carbon dioxide and oxygen. This is Harlean apparatus. I'm particularly interested in that. Because when I did my master's degree in India, we had to do various research works. And this is one of the things I did. We anesthetized patients using chloroform and measured the amount of carbon dioxide in the system. It was an impossible, it was a very difficult thing to measure. We had to take a sample, gas sample from the gas tubes which goes into the patient, and coming out of patients, the sample of the breath, and then put it into this machine and use various reagents so that you can find out how much of carbon dioxide is there. They work out the amount of carbon dioxide in the percentage of carbon dioxide in the system, which is actually very similar to the Van-Slyke apparatus. Van-Slyke apparatus, you could measure it from the blood. Again, you release, you allow the carbon dioxide to come out of the blood, and then using this apparatus, you can measure the carbon dioxide, pressure of carbon dioxide in the system. That's how you measure how much of carbon dioxide is in the blood. This is Professor Zacharias. He's the man who actually changed did a lot of work on acid-base balance. He invented the carbon dioxide and pH electrodes. I met that man along with the other two I was talking about in 1980. Then there are a lot of teaching things we have. There is one, for example, showing the need to extend the at least the chin up, so that you can see them, see the improvement in the air passage. That's an old model sitting over there. But this is actually for CPR. This is one of the early models. CPR was, of course, invented only in 1964. By the time I heard about it, it was 1974, because I haven't heard it in India when I was there. When I came out to Belfast to do my training, there I realized that there is something called CPR. Then we started practicing that. Now it is, of course, a very sophisticated machine, which even talks to you if you want. Blood pressure measurement was very difficult in those early days. Sphygmomanometer was probably the only one we could have. It was difficult during an operation. So we had this oscillotonometers. You connect it and sit somewhere else, and you could measure the blood pressure from a few feet away. That was quite good. It is very easy. I can do everything come up here. But in the old days, we have a model here somewhere in the collection. You just rotate it and this moves in one direction, and so that you can change whatever you want to show it to the students. That was before the days of acetate sheets and slide projectors. I'm sure you all remember those days. I certainly do remember acetates. So what's happened to Ritchie Collection? There are a few more items to catalog. They are currently on display, of course. The entire problem is what happens when you move the hospital. So I decided to do a hospital pass. I handed over the ownership to the Alumni Association in the hope that it will survive the move. So it's up to you to decide what you want to do with it. At least I can die peacefully. Now, I did mention that did I mention that we used to make our own anesthetic inhalers? This is called a flat can. This is a very old one. Basically, you have some holes here, and you connect that either into the airway in the mouth or into the endotracheal tube in the lungs, into the trachea. You put a few holes here and put some anesthetic in it, and you allow the patient to breathe on their own. Now, I challenge one of my colleagues here to see whether he can make one. He's, of course, the cat-loving fellow anesthetist and my drinking partner, or beer tasting partner, David Jones. And he came up with this gadget. It's exactly the same as we used to make it and use it. And he, of course, made it methodically, having 5 holes around it. And we couldn't get the old rubber tubes there, so he put this one. It is the same as old, but it is different. It's modern. So I decided to name it DJ Scan. So I'm going to put it in the display in his honor. So it was a journey for me, recognizing simple things in anesthesia is all what you need to do given a successful anesthesia. It helped me to dealing with those kind of primitive things, helped me to work in whatever place I want. I worked in field areas, I worked in war zones, I worked in places with absolutely nothing. So all that need is some basic things, or you make up your own things and give anesthetic. So basically, you should be able to innovate. Unfortunately, present-day training does not involve change from the standard, uniform, safe kind of anesthetic system. That means you can't really go out and into the field, or there is a big catastrophe. I'm not sure how people will cope with that. We could, because we are used to working with nothing. And of course, I learned how to conduct research with whatever I have. Some machine in the corner, and you clean it up and try to do a so-called research. It may not be perfect, but gives you enthusiasm. Thank you for your attention. So remember, every time something new is invented, something old becomes antique. Thank you.
Mathew, you've had an enormous experience in your lifetime, obviously. One of the things I know that you do is, or used to do, is spend your holidays going to war zones to deliver anesthesia.
Yeah.
In Dunedin Hospital, you presumably have modern equipment. When you go to some of these war zones, what other equipment do you have? Did you have to use? I mean, were there modern equipment in war zones, or did you have to use some of the more primitive things that you've been describing?
And all these things vary depending upon which country you end up. I worked with Médecins Sans Frontières mostly. When I started, they used to go to various places and they had practically nothing. They have usually simple things, some drugs, some old drugs sometimes. But we can always put two or three things together and make a good anesthetic. It's like making a good curry. You can actually find out things. If you look into any operating theater or any place where there is something going on, you can pick up various things from there and do that. For example, we didn't have too many of anesthetic machines or equipment, so we had something called ketamine, which is a very powerful anesthetic drug. I use it extensively in the field. You can use it multiple times for any long periods of time. And then we had airways I was showing there. That holds the airway, help the breathing. Or you can give it things intravenously again and again if you want. We had oxygen generated from the air using oxygen concentrators. So there is oxygen, and you have some sort of inhalation anesthetic agent. I haven't had to use either in the field here. When I was in India, we had to use it. I to use older drugs, but I had to use halothane, which is discontinued in this part of the world. In the field in Middle East, for example, I worked quite a lot in the Middle East. We had to use halothane there, but using my own ways of giving it to the patient with some oxygen and air. You can always invent something if you know what you're doing.
Could you briefly just name some of the war zones that you have worked in? I know you've worked in many.
I've worked multiple times. Basically, take it this way. The America invaded, did I use the wrong word? Iraq. And eventually ISIS came into being. And there was huge trouble in the entire area. So I kind of joined around that time. So I worked in Iraq a few times and Syria a few times. And then I worked in Pakistan and Afghanistan area, that border. They were all troubled areas following some kind of intervention by European countries, mainly, and America, of course. And then I worked in Northern Africa. Again, there was problem with ISIS-related groups. So I kind of followed the trouble. So usually it's for something like 1.5 to 2 months, or sometimes 2.5 months. So I followed all these troubled areas without being low, and usually work for a couple of months or 2.5 months and then go back after 6 months or something. So that's how I kind of travel with the trouble. And then when it is finished, I finish. And of course, I worked with the New Zealand Army for a while.
Sorry?
New Zealand Army.
New Zealand Army, right.
As a helper. I was a few times in East Timor. when they were having action there.
There can't be too many trouble spots in the last 20, 30 years that you have not worked in. It's amazing. I'll just make that comment.
No, I trained in Belfast. There was quite enough trouble.
Well,
trained there.
yeah, but most places. Other people's questions.
Thank you, Mathew, for your talk. I mean, as a surgeon, and I've worked with you and with David, of course, admire what you do to patients during the operation and also postoperatively, relieving their pain. So, as a surgeon, your best friend is the anaesthetist, obviously. Now, I mean, in the 19th century, what was available, you were saying, was ether and chloroform. And I understand that there were some proponents for chloroform and others for ether. Can you elaborate on this, one versus the other? Are there differences, complications? Is one safer than the other?
I use both. I have used both. As I said earlier, I'm one of the probably only living one who has used all those in different formats. The problem was some of these drugs were used in a very uncontrolled way. Chloroform, for example, when I did the study I was mentioning there, we had a specialized vaporizer built somewhere in London. It's not made anymore. It could control exactly amount giving it. So it's a very safe drug at that time. But if you just pour it into a mask, you tend to get problem. The reason chloroform went out of fashion was somebody gave it and patient had a cardiac arrest or something and died. So it doesn't, once it appears in the newspaper or media, in the newspaper in those days, it suddenly goes out of fashion. So it varies with which country you are in. British related countries, as far as I know, preferred either. I was trained, British India used either. But we had chloroform available from the old days, which was used by older anesthetists of my younger days. So there is no particular rule. If you would ask me, the England-related countries use either, and probably that's the way it went.
Okay. As a surgeon, sometimes you have to give your own anesthetic, particularly in places where there's no anesthetist. I have one story. I was working in Africa a long time ago, and there was no anesthetist, and I used actually, I can't remember if it was chloroform or ether, just put it on the gauze, and we put the child to sleep, and it was a child who had an omphalocele. That means part of the gut was outside the abdominal wall, and I was doing the surgery, and there was a nurse who was sort of administering the ether or the chloroform, and I managed to get all the gut back into the abdominal cavity, and then the child woke up and started moving around, and then everything came out again. All the gut came out again, and we had to start again. But in the end, we managed to operate on that child with just some ethyl chloroform on a gauze. The other thing is, you didn't talk about sort of spinal anesthetic, which is another way of giving anesthetics in places where there is very little anesthetic support.
Yeah, that is dangerous. Yeah, believe it or not, I use many cases of simply pouring ether, mostly ether, into mask and give, particularly in children. It is exceptionally good. Only problem with ether is that if you use a lot of oxygen, you have a high risk of a fire or an explosion. But we never use oxygen. We use only air. So it shouldn't be a problem. And of course, they throw quite a lot severe nausea afterwards. Apart from that, it was very safe. But it is in the modern world, they don't accept those kind of things anymore. You had to use more expensive and difficult to get things.
Not to take away from what Mathew's said, because he's used both the chloroform and ether, but there are two talks that I've done here before, Isaiah Dezouche and John Wilkins, which covered this city's debates over chloroform and ether, and which was the safest and also which was the nicest. And of course, the nicest one isn't the safest one. They'll be on the YouTubes for this group.
Just comment. I was a registrar doing anaesthesia in Edinburgh in the early 70s, and the consultant had actually put chloroform in the fluorotherm vaporizer and got us to use it, and said, how did you find that? And I said, fine. He said, well, actually, we're using chloroform, not halothane. Yeah,
I can believe that, because I used to use that in that bottle and in the machine system. Yeah, you could exchange it with anything. It's a very good drug.
Thank you for a fascinating talk.
Yeah, excellent. When you were shown how to use chloroform, that he put it in the vaporizer. Yes. I remember an anaesthetist consultant showing me how to use ether, but he cheated. The patient was asleep, and then he changed the vaporizer to an ether vaporizer. The interesting thing is the induction. Did you see the induction under chloroform? No, because that's the difficult part, I think.
Yeah, I have been this. When I learned, we always use ethyl chloride to put them to sleep, and then maintained with ether or chloroform. They were the same. No, ethyl chloride. Ethyl chloride. It is available to numb the skin here before you give needles. They are very good and they quickly go to sleep, but you can't give too much because it is co-toxicity. So you change over quickly to either or chloroform, they are the same. You get the same. They always move around when you induce. So we had to hold people down. In fact, when I worked in northern part of India, there are very big people there. And they had this need to have their swords with them all the time, or their guns. They wouldn't part with that. So they keep the sword or gun with them when you pour the ethyl chloride and then either on the mask. And so we have people holding them down. That's the only way to be safe for everybody. You can't leave somebody who is big, and they always move. That same video, you can see it in the internet, that shows them moving around a bit of it. I didn't want to show it. So there is a period of restlessness, then it becomes all right.
I'm just so impressed by, you've seen it all. I'm the same era, but you've seen so much more than I've seen. I forgot what I'm going to say now. Yeah, propofol has come in. We haven't mentioned propofol.
Oh, no,
I think the sport has gone out of anesthetics since propofol arrived.
That's new.
It's a joke.
That's new stuff. I haven't mentioned. We have one of them sitting in there, but that is currently used one. That is not old.
Any other comment? Well, if there's no comment, please, everyone, thank Mathew for a wonderful presentation.